Thank you everyone for coming today. I really appreciate you guys. And again, my name is Emilia Garcia, and I'm super excited to share my doctoral project with you guys. I wanted to give you a little bit of background first about how I even came up with this project, because quite honestly, when I started my doctoral project, this was, I would say, probably the furthest thing from my mind. I was thinking things like vaccinations, neonatal pain, just some of those more common things. And what happened was I started taking note of some things going on in the NICU, and we had to do a project in our statistics course that kind of brought this more to fruition. And I really felt that it was God guiding me towards this, because it has become such a passion of mine, and it's something that I know that I've had for so many years and didn't even realize those feelings that I was having of frustration, what really that was about, and that I could actually do something about that. And so that is a little bit of background of how this project came to fruition. The project title is Breastfeeding and Racial Inequities in a NICU, and this was a quality improvement project. My main disclosure is that with the initiation and implementation of this project, we have collaborated or developed a relationship with an organization called Once Upon a Preemie, and so they helped us with implementation of our health equity courses. Next. Some of the objectives of this presentation is to acknowledge and understand the terms related to DEI, diversity, equity, and inclusion, because I don't know if you're like me, I think in general we feel like we basically know what those definitions mean and those words mean, but I gained so much more understanding after doing this project, so I hope that you do too. I want to communicate the benefits of breastfeeding, both on the maternal side and the infant side. And then last, but definitely not least, is to acknowledge that there are disparities that exist in the NICU. So social justice, that's something, a term that I feel like that we've been hearing more and more recently, and it's something so profoundly embedded in our nursing profession. And I believe that is something that we forget about. And if you look in the Code of Ethics for Nursing, it is specifically worded in there that one of our calls to action is for social justice. And for me personally, again, referring back to my spiritual beliefs and how those guide me, I believe that Jesus Christ, that there was no one more that could set an example better than he was. He was such an advocate for social justice. So starting off with my why, and the why for this project. So many leading organizations like the World Health Organization, the American Academy of Pediatrics, all recommend breastfeeding. There are multiple maternal benefits and infant benefits. And on top of that, it really helps establish that early relationship between mom and baby. It's so beneficial, it's so crucial, and it's absolutely beautiful. For terms, as far as definitions for this specific QI project, the definition that we used for breastfeeding was breastfeeding at discharge from our NICU. And because of this special population, the neonatal population, we're saying that breastfeeding can be directly from the breast or the chest, pumped and then given by a bottle, and then also through a feeding tube, because as you know, some of our babies have to go home on feeding tubes. So I feel like this slide could be a little overwhelming and a little complicated, but I want to direct you over to the left-hand side of this slide. Those are some of the benefits to breastfeeding, and these are specific to the mom. I'm sorry, let me rephrase that. Some of the, not the benefits, but some of the issues that mom may have, some of our maternal morbidities are preterm. Black women have an increased rate of preterm birth rates. That's something that's statistically available. There's also Black women have an increase in maternal mortality by 3 to 4 times that compared to white women. Also, Black women have higher rates of cardiac conditions, chronic stress, including hypertension, and also weathering. And what weathering is based on years of racial discrimination, which can accelerate detrimental and progression of physical ill health. And also, Black women, when they give birth, their babies have an increased rate of necrotizing enterocolitis, and what NEC is an inflammation of the GI system, of the GI tract, and it can cause necrosis of the GI system, and then also it can go as far as causing death for the infant. As far as on the right-hand side, you'll see some of the benefits of breastfeeding. For breastfeeding, it has been shown to decrease the risk of NEC for our premature infants. And it also improves or provides respiratory protection. It decreases the rate of SIDS. And for moms, look at the relationship there. It decreases hypertension, which we see a lot in Black mothers and brown moms. It also decreases various cardiac conditions, reproductive cancers, and again, it increases that relational health. So this is the problem. After reviewing our data, and we have an incredible quality team that we have in our NICU, and we have always done such a great job at reporting our outcomes. That's something that we pride ourselves in. But one of the things is that we never stratified our data by race and ethnicity. And what I had noticed is that our overall breastfeeding rates weren't that great. But then I took that extra step and had all of that data stratified by race and ethnicity. And this is aggregate data from the years 2017 to 2020. And as you can clearly see, there was a disparity noted for our Black infants and Hispanic infants, especially when you compare that to our white infants. We had a significant p-value, a statistically significant p-value, meaning that there was a statistically significant difference of our infants of color going home breastfeeding compared to our white infants going home breastfeeding. So that right away raised the red flag, and we knew that there was something that we needed to do about that. This is more of the same data, except this is based on year 2020. And again, you can see that there is a difference in just the overall percentages of breastfeeding at discharge. So the goal for this project was to increase breastfeeding rates at discharge from our NICU by 20%. And we were going to do this through the implementation of health equity and implicit bias training courses. Some of the key components that kept coming up throughout my literature review was equity versus equality, implicit bias, social determinants of health, relational health, and there are so many multiple barriers to breastfeeding. Some of those barriers are care at lower level NICUs, lack of provider concordance, and how often do we see that, no matter where we're at or what situation we're at? Do our providers have the diversity within their group as far as race and ethnicity when they're treating the particular population. So if you're Black, do you have a Black provider, or Hispanic? So do your providers look like you? And when that doesn't happen, that can lead to provider mistrust. And also, there's documented lack of support from the family sometimes as well, not just only from providers and health caregivers. Matriarchal influences is another big factor. So if your mom or your grandmother or your aunts, uncles, cousins, sisters, friends, if they breastfed, that gives you that higher likely chance of you breastfeeding as well. Historical influences related to slavery. Now, I don't know about you, but that was something I had never even considered. And so years ago during slavery, many Black slaves were forced to feed the infants of their white slave owners in lieu of feeding their own children. So I think of that and I think, my gosh, that is incredible. And if I had that in my history, I think that would be a deterrent for me too. I can understand why maybe that might be a factor in our Black mothers not wanting to breastfeed, because it's such a horrifying situation that they were placed in. Social determinants of health absolutely makes every difference in the world, and implicit bias for sure. So we'll talk a little bit about implicit bias. Like, what is it and who has it? I have implicit biases. We all have implicit biases. And they are perceived thoughts, notions, and attitudes that we are socialized to. They exist out of our conscious awareness. And just like this family that's sitting at the table, we sit around and have conversations with our families and friends, and the age group, older people, our younger children that are sitting around with us, and we talk about all sorts of different things. And sometimes when we hear these things growing up, that's how you're socialized to having different implicit biases, and they're outside of our conscious awareness sometimes. And so it's a matter of stopping in the moment and thinking, why am I thinking that when I see this young brown or Black 16-year-old mother who just had a baby? Am I just making the assumption that she doesn't want to breastfeed, or that she must be a bad person, if you will? A lot of times we have those biases, and we may not speak them out loud, but we have them. But if we can identify those and stop and think, okay, I'm thinking that thought. Maybe I need to redirect myself and sit and have a moment and talk with her and really get the real story, because it's always deeper than we think. Can we go back just one more? When we do have those implicit biases, it can impact the care that we give, and it can show up in as far as neglectful care, judgmental care, like I just spoke of, and even privileged care. I've seen it happen, unfortunately, even in our own hospitals, in our own units. You have the CEO or vice president, or hypothetically the mayor's child or grandchild, and everyone treats that family a little bit differently. We all do those things, and so privileged care does lend itself to our biases. So what we did in our unit to make ourselves more aware of our implicit biases is that all our staff had the opportunity to take the implicit association test. And this was a test that was developed I believe it was in 1995 by Dr. lost my, what his name was, Greenwald, I believe. Anyway, at Harvard University, and this IAT, the implicit association test, has since become the national standard for assessing implicit biases. There are a multitude of different tests on here that you can take. There are a few listed here. There's probably about 10, 12 different tests that you can take. So I encourage you all, scan the QR code and get on there. It's free. You can take it. It's very revealing, and I think it really helps you assess those implicit biases, and it brings your awareness to them. So earlier I talked about equality versus equity and the differences, because I think a lot of times we get these confused. Even if you Google equity, it's going to bring up, it won't bring up anything that is health related. It will actually bring up like equity in your home. That's going to be the first hit on equity if you Google that. But there is a big difference. And this infographic by the Robert Wood Johnson Foundation, I love it because it depicts it perfectly. So at the top you can see equality. Everyone gets a bicycle. That's awesome, right? Everyone is getting the same thing, but it doesn't take into account the size of the person, the age of the person, if the person may have a disability or not. But, well, I gave you the same thing that I gave to him, so how is that not okay? But equity, it's so different because what it does, it takes into account each person's individual needs. So I can sit, talk to you, have a conversation, and find out what your specific needs are, and I can meet those needs for you specifically because everyone has different needs. Social determinants of health, and this is another area that I learned so much about. As far as a lot of times we hear access to health care, how that makes it difficult for patients to receive either the highest quality of health care or health care at all. And access is a big factor. But did you know that social determinants of health actually affects our health by 80%? And so social determinants of health are the areas where we grow, where we live, where we work, where we play, where we pray. And so if you think about your own neighborhoods, can you go out and go walking? Can you take your baby for a stroll? Are your children allowed to, or are they safe to go play outside for physical activity in their neighborhoods? So that makes a big difference. And what about places that we work, specifically breastfeeding mothers? There are so many places that have fantastic areas for nursing mothers to go pump during the day. But what if your job doesn't allow that? What if they don't have a space for that? What if the space that they give you or tell you to go to is, well, there's a bathroom, there's a restroom there that you can use, and so is it very sanitary? So if the job that you have to go back to early because you don't have PTO built up and you have to go back to work in 2 weeks or 3 weeks and you don't have family time off, that also inhibits breastfeeding goals. And relational health, this is such a big deal as well. Specifically, like in our own organization and all other NICUs, organizational relationship. So when a baby is born and has to be admitted into the NICU, what happens? There's immediate separation from mom and baby, right? Like, so the baby is either in great need of critical care, whether that's ventilatory support, whatever the case might be. So there's that immediate separation. So right away, we're creating a barrier there for bonding and that those early relational healths, or the early relational bonds for mom and baby. In staff-parent relationships, that's huge Because if you are a nurse in the NICU or in the wellborn nursery and you're in a hurry, you have lots of other patients to take care of, and so you don't stop and take the time to talk about the benefits of breastfeeding for mom and for the baby. You don't have time to educate, or maybe you just don't even know yourself. Sometimes our own nurses don't know the full benefits of breastfeeding for mom and baby, so it does take a lot of time. And I know specifically today, our NICU is booming and it's busy, and so sometimes our nurses are rushing around and doing the best they can, and sometimes stopping and having a good long conversation is not always the priority, which makes it difficult for a lot of nurses, because I know they would rather be doing some of those things. And parent-infant relationship, this is the big goal. And for them to know that they are the most crucial and beneficial partner to their baby. And I think it's so important that we raise and advocate for our families to be the primary caregivers, because they are. I think so often we call ourselves the primary caregivers, and sometimes also we refer to our parents as visitors. They're not visitors. We are into their lives. And so I think even reframing some of those definitions would be really helpful. So the design and methods of this project took place in a 43-bed level 4 NICU in urban West Texas. We implemented health equity and implicit bias training courses to 125 neonatal providers and staff. We did pre and post intervention through our, by using our VON data, which is Vermont Oxford Network, which we are a part of, which is a worldwide database. And we used PDSA cycles, the model for improvement, by Langley for our QI project. The intervention, like I mentioned early on, we developed a relationship with Once Upon a Preemie. They have e-learning courses online. There are 4 courses, and each course has a, they're all related, they all have C&Es attached to them, and all had surveys at the end of each course. And so again, I highly encourage you all to scan that QR code and get some information on Once Upon a Preemie. The president of this particular company, she had her own 26-weeker, and so a lot of her efforts were based on her own personal experience in the NICU. So our results. So what happened? The implicit association test, as far as addressing implicit biases, that was not a mandatory ask. That was something that we offered to all of our staff and told them that they had the opportunity, and 66% of our caregivers at the bedside went ahead and took advantage of that opportunity to take the IAT. And as far as our course registration, we did have 100% registration, but as far as course completion, still was really good at 94% of our staff, including neonatal providers, which were the neonatologist and the nurse practitioners that completed the courses. So here are the results. We talked earlier about the aggregate data from 2017 to 2020, and you can see those numbers in blue, and then also 2021. So quarter 1 was the first data that we collected post our intervention. Our intervention, the health equity training courses, ended in December of 21. And so then our Q1 data was the first time that we collected any data, and I was so nervous about it. But as you can see, we had tremendous success. Our Black infants, look at that, from approximately 40% to 75% going home breastfeeding. After Q1, our Hispanic infants, you can see that was actually lower. So that showed us an area that we had an opportunity for improvement. And then for Q2, here we are. We're still making progress in our Black population. And we have increased the numbers of breastfeeding going home for our Hispanic population and also for our white infants. And overall, our breastfeeding rates for our NICU in general are so much better than they were before we started. So that's a win for all of our babies, no matter race or ethnicity. So in conclusion, I encourage everyone to look at your outcomes through the lens of equity. Stratifying your data will show you if there are any areas of opportunity for improvement, and I think it's so important to do. Sustainability, that's the big thing. You know, like we don't want this to be one and done, 1 year, and everyone's all, high and excited and hyped about DEI. We want this to be an ongoing, I don't even want to say initiative, because it should be who we are and what we do. At Covenant, part of our mission statement is know me, care for me, ease my way, and we take care of the poor and vulnerable, and I think anyone fitting into marginalized populations fits those definitions. Also for sustainability, I think one of the biggest things that we are still working on implementing is having a family member involved in your QI committees, because they bring so much information to your group because it's through their own experiences. I think so many times as staff and as hospital personnel, we come up with policies and processes with great intention, thinking this is going to be so great for our patients, it's going to be wonderful and awesome, but we haven't even talked to the families as the primary stakeholders. What are we missing? And they are the only ones that can tell us that. So by implementing family members into your quality improvement projects can help change the processes that we are trying to implement, and they have fantastic ideas, actually. Again, acknowledging that disparate outcomes do exist in our NICU, which is a tough, kind of a difficult pill to swallow, because I think thinking of a neonatal perspective, you wouldn't think that would happen. But in the NICU, I believe that because we don't only treat the baby, we're also treating the family, because they are a unit together. And so by incorporating them more, and again, like you said, elevating them to that role of primary caregiver, that's where we can do a lot better. Equity is an action. And I was on a podcast or something, and Emmanuel Acho was on there, and he said, it's seen in your outcomes. It shouldn't just be the optics. And I think so many times, so many organizations, we say that we are promoting DEI and that it's a priority, but that is an action. Like if you can say that we have a chief diversity officer, etc. But just because you have those people in place, are you really doing the work that it takes to make this a true and real strategic priority? Quality improvement. It has shown with this project, I do believe that it is an effective strategy to improve our outcomes. And definitely nursing has a huge responsibility to improve and implement social justice at the bedside. And that is everything. Thank you all. Does anyone have any questions?
Questions for Dr. Garcia?
I think it was a great project. I applaud you for jumping into this. It's not easy for people to look at their own biases and to really see how the way they react may impact other people's health. So I think this could be carried across the whole hospital, not just in the NICU, but for everyone to be able to realize that what I am doing may impact someone's life. I think it was excellent.
Thank you. Thank you. I totally agree. When we first talked about introducing the implicit association test and we started doing that, there was some grumblings about it. I think a lot of people felt offended because they felt like they were being told or accused of being racist. And so it was difficult at times, but I think and for me, I'm not a very confrontational person, but when you know that it's the right thing, it makes it, I'm not saying it makes it easy, but it makes it doable. And it's what continues to drive that passion to make sure that you continue to do the next right thing all the time. Yes,
I want to echo that, how much I appreciated you addressing social justice and seeing the implications for that, because those social determinants of health do make such a huge impact on our health.
Yes, sir.
I think you said 80%?
Yes, sir.
Which I teach community health at the undergraduate and graduate level. And a lot of times nurses don't get, because I work at ICU, why do I have to know about the food bank? But they don't understand that. So I plan on using some of your material in class, helping my students to see the implicit bias and stuff like that. It's very, very good, very helpful. Thank you.
Awesome. Thank you.
I was just wondering if you ever, this may be a completely different topic, but is there bias, like if somebody comes in and it's their fourth child, as opposed to, well, they've had 3 other kids before, so they know, so they're not going to get the education. You know what I'm saying? Like,
I do.
I remember seeing that. I worked on postpartum briefly, and I remember some nurses saying that it's their third child, so they're not going to spend much time, but every child is different.
Yes.
Every baby's different.
Yes. You're absolutely right, because there's so many times when if we are having our rounding, which we do outside, we have bedside rounding, and then we have rounding that we do as a multidisciplinary team. And some of the things that are discussed is, well, this mom's a G7, so okay, well, she knows. Or she had a baby in here 2 years ago. But you're right, it's completely different. And I feel
had a bad experience with the other 2. That doesn't necessarily have to happen.
Right, absolutely. And it does make a big difference. Mm-hmm. And especially, I think a lot of times that we see some of the biases is if mom is positive for drug use, then there's a lot of biases there towards mom, and well, this is your fault. But I think what we don't do well is stop and realize that it's always deeper than what we think by literally skimming a chart, because we don't know social determinants of health and other things that may be going on. And that is something that actually I've been working with our social worker, and she has implemented a social determinants of health questionnaire when she does her intake, and that has helped with her allotting resources and things like that. And because of that, we're waiting on a grant that we applied for to have a mini food bank type food pantry in our NICU available for some of our families who are food insecure. So, yeah.
You know, that comment is so interesting because it is true that whenever, as nurses, we encounter patients that have made bad decisions, that it's kind of like, well, hopeless case type of thing. But in reality, that's our commitment as a nurse, is to impact the health of all, including those where it might be more difficult. And so continuing to pursue that and to say, how can I impact the health of this patient? Because that is my role as their nurse.
Absolutely.
And to make a difference for them. I was interested because it was interesting because what you said about whenever you go and you talk with a group of people about biases, that defense does come up, right? Because they're like, I don't have implicit bias. Why are you thinking I have that? When in reality, we all do, because we just grow up with that, and things that we hear, and things that we see, and it's just there. And so recognizing that is such an important first step. I was really impressed with the rate at which the staff engaged and took the course. Those were incredible rates of engagement there. How did you accomplish that? Because that was probably really difficult.
Because we made it part of their yearly education. And so, but that being said, you would think we would still have 100% when we didn't. The implicit association test was voluntary. That one we did not implement through the yearly education. But yeah, and what was really neat is that we have, which I didn't have on or present, is we have a lot of qualitative data because each course ended with a survey. And some of the responses, there were some really not nice ones, but the good ones were so fantastic. Like, I didn't know, I will do better, I would like to know more. So that qualitative data in and of itself was so exciting for me to see. And I was so thrilled that a lot of the nurses did take the time to put those responses in, because it was really helpful for us to know how it really impacted them. Because, with education, your yearly education, it's one more thing to do. And so to know that a lot of nurses got a lot of good out of it was super exciting. So, yeah.
So the ongoing impact of that in that NICU, and then even for the nurses that weren't there during the project but that will come on and that will hear about it, and just elevating that level of care there is something that your project and the fact that you did it will just continue to do. So congratulations.
Thank you.
Dr. Garcia, this is such an important work, and you've just done a masterful job. We're just so very proud of you. This is such important work. And I have just a question. This is kind of a broad question. I know that often in DNP education, our frontline providers that are DNPs are asked to think about the cost benefit of quality projects. As we know, missional alignment is huge, but as you said, we have to be able to also show that when it's appropriate, that it actually, resulted in cost savings. So it seems like that you would have the potential down the road of showing that there was greater satisfaction, even with moms that are breastfeeding and staff. Have you given any thought at all to how a metric like that might help your hospital or your facility capture outcomes that would be, useful to show that this not only is missionally aligned and the right thing to do, but it may even help us fiscally?
I have thought about it briefly. I think it's a fantastic idea in the sense that, especially because through Providence St. Joseph, they're the ones that funded the project. I sent in the information and and all the forms and paperwork necessary, requesting the funding for that project. And I think they would love to see the cost-benefit ratios and improvements associated with that. So that being said, I have thought about that for a little bit, but I just don't know how to quantify the breastfeeding. So like, does that mean you have to assume the baby is going to be taking X amount of volume of formula? So that's the part that has me a little bit stumped. So I would love to see if that was something that I could do, and maybe you can help me with
Well,
that.
groundbreaking work here. And I just thought I'd throw that out there because I know that carrot is held out, often in DNP programs to get the student to at least think about that. And it is a challenge for us as nurses. We do the right thing and the next right thing, but being able to bring that when we can in a way that others that are not nurses, who haven't been enlightened as a nurse yet, can see that it actually maybe improves patient satisfaction or other literature. I was just curious about that, if you had thought about that. And you are so brilliant. I think if you give some more thought to that, you might be able to do that if you want to.
I think it would be fantastic, and I think the system would definitely appreciate that type of analysis for sure. And I would love to be able to give that to them because they were definitely generous in offering the funds and providing the funds for the project. So, yeah. Okay.
Comments? Well,
Excellent job.
Yes, give her a big fantastic job.
Thank you.
Thank you so much for your time presenting today.